Okay, welcome everyone. Thank you for joining us for today's EACTA ICU webinar, Can We Avoid ECMO in the Management of Post Cardiotomy Shock? My name is Dr. Philippe Godard. I am the head of the Cardiothoracic ICU department at the Montpellier University Hospital in France. And I am also the chair of the ICU EACTA Subspecialty Committee. So I'm pleased to introduce the two moderators of that webinar. First is Dr. Peter Russell from Brussels, Belgium. He is an EACTA ICU committee member. He is also a cardiac anesthesiologist and intensivist at the Flemish University Hospital of Brussels, with a special assignment as the head of the transformation program of the cardiological care plane and clinical coordination of intensive care. He has a special interest in cardiac anesthesia, intensive care, patient blood management, TE, data registration and quality assessment and improvement, teamwork, anesthesia overseas, and so on. He is a past president of EACTA and served as a representative council member and board member for 16 years. He was an affiliated member at the ACA from 2014 to 2016. He is a member in the SCA and the EACMA, Dutch Association for Anesthesiology. He has more than 50 publications and book chapters. The second moderator is Dr. Daniela Passero, and she is from Turin, Italy, and she's working as a staff anesthesiologist of cardiac intensive care unit in the Department of Anesthesia and Intensive Care Medicine at the Città della Salute e della Scienza Hospital in Turin. Her main activities and responsibilities include organization of clinical activity of cardiac intensive care unit, infection monitoring role also. She has a clinical research activity on postoperative pulmonary complication and pulmonary hypertension in cardiac surgery, critically ill patients with sepsis and acute kidney injury, lab research on septic model and translational research in septic patients and cell culture, organ procurement activity and protective ventilation in lung donors. She is a member as the EACTA Representative Council and ICU and VAD and transplant committees. So now, please, Peter, come to introduce the webinar and the objectives. The microphone is yours, Peter.
Thank you very much, Philip, for this very nice introduction. I'm really excited for this webinar, which I hope you will be very happy with the end. And let me shortly introduce you to the objectives of this webinar. Actually, at the end of which you should understand the current evidence and the best practices, how to use mechanical circulatory support after post-cardiotomy cardiogenic shock, as well as to avoid it. You will get a better understanding of the indications and contraindications, as well as the different types of using ECMO and related devices in the treatment of post-cardiotomy cardiogenic shock. As well, you should understand how can we avoid and how we could use balloon pump, anatropes, and vasoporters in order to have the best treatment for these patients. We will address as well the use of additional forms of cardiac assist, temporary cardiac assist, like ventricular assist devices, and as well you will have a better understanding of how TE should be used in order to help the introduction as well as the proper functioning of this particular treatment. So I hope you were excited as I am about what's coming up. Just to make sure that you use this webinar appropriately, So we will address questions after each of the presentations. So please, if you have any questions, type them into your chat box, and we will bring them up during the presentation, and we will handle them and try to have some time for questions as well at the end.
Now I'm pleased to introduce the first speaker of today, Dr. Antonio Rubino from Papworth, UK. Dr. Antonio Rubino completed his training in anesthesia intensive care in Italy in March 2012. Subsequently, he moved to the UK in April 2012, and he commenced his post of anesthetic senior clinical fellow and ECMO fellow at Papworth Hospital. He was appointed as a consultant in September 2013. And is currently working as a consultant anesthetist and intensivist, where he specialized in cardiac and thoracic surgery, heart and lung transplantation, pulmonary thromboendarterectomy, and ECMO topics. He is the director of the Papworth Intensive Care ultrasound courses and clinical leader for organ donation in his hospital. So, to highlight the credibility and expertise on this field, we'll introduce the talk that is on the use of ECMO for post-cardiotomy cardiogenic shock, new merits. Thank you, Antonio. Please.
Good afternoon, everyone, and thank you to the organizer and to the chair of this fantastic EACTA webinar. And I have the chance, the pleasure to talk about the use of ECMO for post-cardiotomy cardiogenic shock and what are the new merits around that. And I'll try to take an overview, a general overview, starting with why we do ECMO post-cardiotomy. And we should define the post-cardiotomy, what post-cardiotomy cardiogenic shock is, which is defined as an inability to be weaned from cardiopulmonary bypass despite maximal inotropic support and balloon pump. And there is a specific in the guidelines, in the reviews, there are specific physiological parameters of what is defined, what is behind the post-cardiotomy cardiogenic shock. But what is not exactly defined is what is intended for maximal inotrope support. For who is familiar with ECMO, who has been working with ECMO for years, this picture is really familiar. It's from US. It was the first successful weaning from VA ECMO, not from post-cardiotomy. Is a patient with treated for respiratory failure post road traffic accident, and was we can see from the 70s up to nowadays how the technology has changed, and since then how many trials and how many retrospective data as well, a huge amount of data we had to define what we are up to now. And when we talk about ECMO and VA ECMO, then we need to define difference between central VA ECMO and peripheral VA ECMO, and when we use what. So central VA ECMO is possibly the most similar setup to a cardiopulmonary bypass. Is achieved by the insertion of cannulae in the right atrium and the aorta or in the axillary artery. Is a central cannulation done by surgeon with the chest open, which has clear advantages because we have a chest already open per surgery. We are bypassing the heart and we are bypassing the lungs, but we have an antegrade flow. So from that point of view, probably it's the most between the two setups is the more physiological type of circuit that can guarantee high flows. It can guarantee to the surgeon easy access for LV venting if the decision is to perform a surgical venting. And in a way, if we like or not, we do bypass the lungs, but we can apply a protective lung ventilation. It does carries as well disadvantages and risks. So bleeding, having a chest open, and risk of coagulopathies due to the difficulties and sometimes of struggling in getting a proper patient warmed up with a correct temperature, and risk of infection. It's not easy to mobilize in ICU a patient with a chest open with a central cannulation, and is a procedure done surgically, and the weaning from the ECMO needs to be done again surgically. So the patient needs to go back to theater and be weaned by a surgeon again. And if we like or not, we said we are bypassing the lungs. We can definitely apply protective lung ventilation, but it is true that we are decreasing the blood flow through the lungs. So actually we are not effectively perfusing our lungs. VA ECMO is not, a central VA ECMO is not without risks, we said, and one of the complications that can happen is the loss of pulsatility, the blood stasis in the ventricles. And when we have a setup where we are bypassing the heart, and the heart that is not able to eject properly, with a blood stasis in the ventricle and high risk of thrombi into the ventricle. Peripheral VA ECMO, on the other hand, is a more simplified circuit, is, let's say, commonly used anyway, especially when DLV unloading is not a priority. And is an approach that is definitely less invasive and simpler than the central configuration. We can close the chest, we can wake the patients, and we can assess them neurologically. And we can definitely secure the cannula much more than we do with a central configuration. It is, though, an anti-physiological way to run the circuit into the aorta. We do have a retrograde flow, and we are increasing the afterload quite sensibly for a left ventricle, which has already a significant impairment. So the LV distension is usually an issue that can be exaggerated or can be worsened with a peripheral configuration. And a peripheral configuration, it does carry as well further risks. So if we are concerned about pulsatility and DLV unloading with a central VA ECMO, this concern is possibly even more with a peripheral ECMO with a impaired function. And I'm sorry, these slides are just still images, but I can assure you that that aortic valve is not opening at all. And the issue is the retrograde flow with a highly oxygenated blood coming from the femoral artery, and blood very often deoxygenated coming out from the left ventricle. So it is very often the case to have a patient with an upper part of the body or right upper part of the body which is less oxygenated than the rest, so the classical, the well-known Arlequin syndrome. And as we said, one of the complications of peripheral ECMO is definitely having some leg ischemia or some peripheral complications. So the indication is usually the reperfusion cannula is a must to do, reperfusion line is a must to do, but even with the reperfusion cannula, the leg ischemia is very likely to happen. So nowadays we are moving more and more towards what are the strategies on VA ECMO, what are the strategies of LV unloading, and not surprisingly, the surgical LV venting is one of the least favorable options, and we are moving more and more towards ways to unload the ventricle and giving a functional rest. And one of the most favorable options is the use of the balloon pump and drainage through the LA, usually through the pulmonary veins overall. So the main aim while the patient is on ECMO is how to try to reduce as much as possible the afterload and reducing the risk of thrombi, ensuring pulsatility, and then trying definitely to provide a functional rest to our heart. We are moving more and more towards use of the ECMO with other mechanical devices, and possibly this is the new merit we are going into. So the ECMO is not seen itself as a bridge to recovery or as a bridge to transplantation itself, but most of the time is seen as a bridge to another device. So more and more the use of the ECMO is not happening on its own, it's happening with the use of other devices. And if we like or not, the use of the balloon is very often seen not only generally in cardiac surgery, but in the patients on ECMO. So there is a nice review from a few years ago that showed how the patients on ECMO seems to be that the patient on ECMO and balloon are more likely to have an increase and reduced numbers of complications and a decrease in hospital mortality overall. We are seeing more and more as well, probably more complicated setup with the use of ECMO and Impella, or ECMO and VAD, that most of the time is often a bridge to a further mechanical support. But this is just to show how the LV unloading is not necessary, it's not always a success while the patient is staying on ECMO. So, going through challenges, it is difficult definitely to recognize as well when we should consider ECMO in the post-cardiotomy cardiogenic shock. And if looking in the literature, we can see that early is the better. It is true that an early cannulation and less, if we can reduce the time of the heart being stressed with inotropes, is definitely what is favorable. It is true that we should start considering probably the use of a mechanical device in the early stage, probably even when we are anesthetizing the patient. So an early decision, an early making progress, or anyway trying to decide about future strategies once we are coming off bypass, are probably more than welcome before probably starting surgery. If it's difficult to understand when to consider ECMO, it's possibly even more difficult to understand and more challenging to understand when we should wean the ECMO. And there are nice diagrams and nice protocols including the use of the echocardiography and the weaning of the ECMO. But we should remember that as long as the patient will be on a minimal support on ECMO, it will be probably challenging to understand whether that patient will be definitely successfully weaned from the ECMO. Challenges are increasing, and are increasing as well, especially when we think about who we should put on ECMO. So the ECMO is not for everyone, and the scoring system, there have been several scoring systems validated looking at the retrospective data, and the SAFE score is quite often accessible scoring system, accessible online, developed by our Australian colleagues, which is a really good scoring that predict once the patient is on ECMO, predict the survival of the patient. It does give a very, very, very good estimated survival of the patient. It is a scoring to be applied once the patient is already on ECMO. So it's difficult to find scoring which tell us whether the patient will merit or not an ECMO. The ECMO guidelines, the ELSO guidelines, are quite adamant on the contraindication, on what is absolute contraindication, and saying we shouldn't consider ECMO when we have a patient that has an unrecoverable heart, which is not a candidate for transplant or for VAD. We shouldn't consider ECMO whether we have a patient in front of us that is an elderly patient with several chronic comorbidities. What is difficult sometimes is trying to define what is considered elderly patient and how important those comorbidities would be. In our experience, again, retrospective data on central ECMO post-cardiotomy, we try to define that age as 70 years old as a cutoff. So this has been our age cutoff, where our experience, our survival of the patients has gone terribly down. And our data probably are not far off from the data that are out in the literature. So there is a surprisingly high number of patients weaned from the ECMO. So slightly more than half of the patients are successfully weaned from the ECMO. 1/3 of these patients are successfully discharged from the hospital. And if those patients discharged from the hospital, well, 2/3 of those patients do well. So overall, we have 1/3 of the patients with good survival at 1 year. Our data are not too different from what is out in the literature, with much bigger retrospective data. When we talk about subgroup though and sub-analysis in our results, well, there are probably two categories of patients that have raised our results. So transplant patients and pulmonary thromboenterectomy patients have been patients that have done terribly well post-cardiac surgery while they were on ECMO. So the patients, we had a very good survival on patients with primary graft dysfunction put on ECMO and patients with pulmonary thromboenterectomy, where the problem probably wasn't the post-cardiotomy cardiogenic shock. In those patients with a pure post-cardiotomy cardiogenic shock, so patients with a graft and valve disease or more complex cardiac surgery, well, those patients didn't do very well overall. And probably if we look at the sub-analysis, those patients probably, our results are probably less than one-third of, so we had probably less than one-third of survival. Just to conclude, so definitely we are talking about there is an increased burden for patients who otherwise die after cardiac surgery. We are talking about patients that would not be able to win from bypass at all. We should remind though that the patients put on ECMO, of those patients, one-third of the patient with on post-cardiotomy VA ECMO that are able to be weaned from the bypass and are able to be discharged from the hospital, well, those patients do well. So it's only one-third of those patients that have a good survival, but those patients survive, and they do survive after 1 year of surgery as well. What we didn't look, though, was the quality of life of those patients. The patient selection is definitely the key, and the key is only to look at what the comorbidities would be, but probably most important is to see what the age of the patient would be. And the patient age has played an important role in affecting the prognosis of these patients. Nowadays, we are talking less and less about the use of the ECMO itself as a bridge. But when we talk about the ECMO, probably there is a future and there is definitely a merit of the ECMO. We are associating the use of the ECMO with probably further mechanical devices, hence the balloon pump of the use of the Impella and BAD devices. The point that the focus has been on the LV unloading, which is proven difficult while the patient is on ECMO most of the time. We do need large prospective multicenter data. And if we have those data, those multicenter trials on VV ECMO, well, when we talk about VA ECMO, most of the time we have a retrospective data. This is possibly due to the difficulties of running and designing a trial on this category of patients overall. It is true that while we have patients on VV ECMO, we always talk about buying time with the VV ECMO. Well, when we are on VA ECMO, we are not buying any time in the way the clock is ticking. And this is why as soon as the patient is on ECMO, or even before the patient goes on ECMO, we should think of what is next. And I'll leave you with a final probably consideration on thinking of how difficult are these patients overall, and how complexity, the difficulties and the challenges around the ECMO and the decision-making progress is definitely reflects the complexity of our patients overall. And the limited chance of success, we said, is only one-third, and sometimes most of the time it's less than one-third of survival on those patients. And nowadays, with a limited budget and limited resource, the decision that is left to the clinician is possibly even more difficult. And almost the decision will always be anyway to the individuals and to the clinicians. And yes, scoring system might help, but they won't take away the final decision, which will be up to the clinician. Thank you very much.
Okay, excellent. Thank you very much, Antonio, for your excellent presentation. You underlined very well the key problem, the selection of the patients and the heterogeneity. We have some questions from the floor. The first is peripheral VA ECMO higher risk of bleeding in comparison to central configuration after post-cardiotomy VA ECMO?
Thank you for your question. Thanks, Daniela. I think the first probably, I would say straight away, no, it's not. And theoretically, you would do a peripheral VA ECMO because in this way you can warm up your patient, and then you can probably correct in a way or preserve your coagulopathy or avoid coagulopathy. While on a central VA ECMO, it's more difficult to keep the patient warm, and having a patient cold, you can have new phenomena for coagulopathy. So in principle, probably one of the reasons whether we should decide whether to go for peripheral or for central ECMO, if we think of the pro and the cons, well, let's say coagulopathy might be a pro for closing the chest and warming up the patient. What it is easier with a central ECMO, which is not the reason why you shouldn't do or you should do, what is it is easy in terms of coagulopathy and bleeding is the fact that you have a chest that is easily accessible and you can surgically review a chest that is already open. So if there is an ongoing bleeding, probably is a way to find out. Having a chest already open is easily accessible. But definitely, probably, if we follow physiological parameters and the physiological thinking, we should think about having a chest closed and a patient that is naturally warming up.
Thank you, Antonio. We have one more question from Canada. They say they don't have an Impella device. So can you explain better the advantages of this system of unloading of the left ventricle? Thank you.
Yeah, the Impella, we do in our center, we do a few Impellas. Historically, we have done more ECMO than Impella, and the Impella is recently coming up with us. And there are clear advantages of using the Impella, because if we see how the Impella works, so it does have a percutaneous insertion, so you insert percutaneously through the femoral artery or through the axillary artery or through the subclavian artery. So already the access is a percutaneous access. And it does go into the left ventricle, goes across the aortic valve, and it does theoretically unload the ventricle much better than an ECMO would. There are, though, disadvantages. Anyway, there is a learning curve, and it's really important to know how to perform and how to position an Impella. It's not straight away, it's not easy. There is a learning curve with that. And there is as well a need of more trials. So far, we don't have many trials showing the superiority of an Impella compared to other devices, other mechanical support. As probably I mentioned on the talk, the way as well we have been using the Impella in our center so far, and we are looking towards moving from this way, is so far we have been using in patients on ECMO where the ECMO, the unloading wasn't working. So the question would be, should we use the Impella as a first probably mechanical device? And remember, with all these mechanical devices and the Impella as well, is usually they don't last too long anyway. So usually as soon as you put a device like that, the Impella as well, you should start thinking of your plan B. What is your next step overall? So theoretically, the Impella, yes, has some clear advantage. So it does unload. If it is well positioned, it does unload the ventricle very well. But there are technicalities with that to be learned and to be quite confident with.
Okay. Thank you, Antonio. One more question. Do you use a decision algorithm to decide if a patient is eligible for ECLS post-cardiotomy?
I'd like to say yes. In practical terms, we don't all the time. So we have an internal policy and agreement in the way of having 2 or 3 consultants agreeing in putting a mechanical device in these cases. We all know our cutoff. We have been reviewing our experience, and we have seen that in patients over 70 of age, there is a mortality probably in our experience of 95%. So almost that is a big no overall. But we usually go through common sense in the way of, again, it's difficult in the decision in the right of the coming off bypass when the adrenaline is kicking as well. In the clinicians, it's really difficult to say yes or to say no, probably in that cases. What we are trying to establish is actually to see if some of these patients, not all of them, of course, but some of them can be predicted before. So in the anesthetic review, when we do the pre-assessment review, we start and we do the MDT review of the patients. We start asking the question. So that is probably the best moment to ask whether a patient would be suitable for mechanical support. But this one doesn't exclude all the patients, because there is the implant that happens with surgery as well, and in the implant probably is more difficult. So if we follow the definitions from the post-cardiotomy cardiogenic shock, we should probably think about putting all those patients. But in our experience, age is the first probably decision point where we say, yes, we should consider or we shouldn't. And the other criteria as well is exit. So whether a patient could be suitable for transplant or for further mechanical device, or whether there is an exit strategy. So exit strategy is always something to consider in these patients.
Okay, thank you so much, Antonio. I think we have to move on. I'm sorry, there are a lot of questions. Maybe we can try at the end if we have time. So I give you talk to Peter. Thank you, Peter.
I hope that with this webinar, we've been able to provide you with a good overview how ECMO can be used and should be used, which are the caveats, and as well that ECMO should be seen within a whole arsenal of therapies. And I think that basically Dr. Antonio Rubino from Papworth, the UK, he explained very clearly the basics of ECMO treatment. He addressed as well the risks and the complications which are involved, which are really vast. And actually, he was mentioning, like other lectures, that the outcome after post-cardiogenic shock in patients who need the ECMO is not very good. And in the best centers, it approaches somewhat about 1/3 of the patients who recover from ECMO. However, this is very dependent, as he mentioned, upon a very good selection. He insisted on the fact that such selection should be a multidisciplinary decision. And I think his final words was actually that every patient is different, ECMO is complex, and for every case we need a tailored approach in order to have the most benefit and avoid the side effects. Next was Dr. Isabelle Michaud from Brussels, Belgium, who gave us an overview of post-cardiotomy cardiogenic shock. She mentioned the heterogenic literature, which is very difficult to interpret and to provide evidence what's the best treatment in this situation. She reviewed the use of balloon pump, which should not be dismissed lightly, and is probably very valuable, particularly in the preoperative setting in these high-risk patients, as well as in combination with ECMO in order to provide afterload reduction, which may be a major problem with ECMO. She reviewed as well some of the anotropics. She pointed out to the risk of very high doses of epinephrine. She mentioned let's say, somewhat care we should have with the use of milrinone. She reviewed as well levosimendan, which was very promising, but still waits to find its niche where it is most useful. Again, here, preoperative setting, it's probably the best way to use it. Next was Dr. Ouattara from Paris, who explained that next to ECMO, we may use other treatments, other assisted treatments like ventricular assist device, be it left ventricle, right ventricle, or biventricle, And this should be seen more as, let's say, a second approach after the ECMO in order to bridge to something else, maybe an assist device for when you're lucky in heart transplant. He reviewed as well the Impella device, which is very promising. Particularly, we know the high flow variants, as well the Impella which you can insert surgically from within the apex or through sternotomy, as well as the new upcoming Impella for right ventricular assist. All very promising, but still very early phase studies. Dr. Priya Menon from Leipzig gave us a good review how TE guidance should be used in the insertion of ECMO cannulae, balloon pump, as well as Impella. Not only insertion, but as well in the daily follow-up of this patient, TE guidance is of paramount importance. Finally, Dr. Philippe Godard, he gave us the viewpoint from the intensive care to these patients. And with that, I think, I hope we have give you a good overview, which will allow you to make better use of ECMO in your patients. I really hope that you enjoyed this webinar. I wish you a very good evening. Thank you for your participation from wherever you are listening or looking. And now I'm giving the final words from this webinar to Dr. Godard. Dr. Godard, the webinar is yours.
Thank you, Peter, for this point-by-point wrapping up. Now I think we are good for now. Thank you, everyone. It was a pleasure being with you today. As a take-home message, I would like to say that VA ECMO for refractory post-cardiotomy cardiogenic shock needs to be started early when inotropes don't work and needs to be customized to patient and surgical situation, including a combination with intra-aortic balloon pump. Left ventricular unloading is mandatory and minimal pulmonary flow needs to be preserved as much as possible. Anticipation or prevention is a key point for the use of balloon pump and probably levosimendan in selected cases. Selective left ventricular support or combined ventricular assist devices are promising options. TE is absolutely essential for the indication, the setting up, the follow-up, and the winning of mechanical circulatory support. It's time now to close the session. On behalf of all speakers and moderators, I would like to highlight and emphasize the value of Professor Mohamed El Tahan as EduCom Chair, being instrumental in organizing this EACTA webinar. This is my pleasure to introduce Professor Fabio Garacino, the President of EACTA, to conclude and close the webinar. Please, Fabio.
Good evening, everybody, dear colleagues. Due to unpredictable technical problems, I'm not able to lively connect with you at the end of this webinar, but I really wanted to thank all the people who made this webinar happen. So it is a pleasure for me, on behalf of the EACTA Board of Directors, to thank the speakers who did an excellent job, and we are very grateful to them for their commitment to EACTA. We know how hard it was to prepare the lectures, to go through the rehearsals with Professor El Tahan in order to make everything work fine tonight. So many thanks to all the excellent speakers. A special thank to the ICU subcommittee. All these educational activities are prompted by our subcommittees, are supported by the subcommittees, and we are very grateful to our colleagues and friends in the subcommittees for supporting these educational activities. I really wish to thank a lot the sponsors who supported us and allowed us to make this webinar possible. So I really thank Abiomed and Orion Pharma for their support. We are really grateful. They are supporting not only this webinar, but in general, our educational activities and scientific activities. And so we consider them really part of this team producing education and scientific activities for our community. Let me thank the team from Rome, the team from AIM, our association management team. They did an excellent job in supporting and backing all this activity. And last but not least, as we used to say, a great thank to the educational committee of EACTA and to its chair, Professor Mohamed El Tahan, who is so active and is supporting, promoting, and managing all these interesting educational activity. Many thanks. Well, we apologize for not addressing all the answers. This is due to the limit of time, but EACTA will publish all the answers by speakers on the website. So before saying goodbye, I really wish to remind all of you that the next EACTA webinar will be in March 2020. So keep on following us. Thank you so much for attending and joining. Bye-bye.